Owolabi, would you please stand and keep standing, please, while we take a citation? Owolabi has authored and co-authored numerous peer-reviewed publications in reputable scientific journals, contributing substantially to advancing in the understanding of neuropsychiatric disorder, translational pharmacology, and evidence-based approaches to drug discovery and repurposing. His work bridges experimental neuroscience with clinical therapeutic applications, particularly within the context of precision medicine and personalized psychiatry. In addition to his research achievements, he's actively involved in undergraduate and postgraduate teaching, curriculum development, mentorship, and research supervision across medicine, pharmacy, physiology, and allied biomedical sciences. His commitment to scientific mentorship has helped shape the medical scholars and healthcare professionals within and beyond Nigeria. Please, with a resounding clap, let us celebrate the presence of Professor Owolabi.
For my lecture, we cover the following themes. We will look at what precision medicine is and how it's applied in psychiatry. We x-ray the shortcomings of contemporary psychiatry. We will look at the relevance of neurocircuits in the biology of psychiatric disorders. We'll talk about what neurocircuit biotypes are and how polymorphism of neurocircuits can shape the manifestation of psychiatric disorders in people with mental health conditions, and how that can help us to develop precision psychiatry. And of course, we also take a look at what the future holds for psychiatry if we are able to fill that gap as it is being filled in other parts of the world, and also probably to inspire us as upcoming neuroscientists, right, to also contribute, right, to more development in neuropsychiatry that will contribute to development of neuroscience that will drive the future of clinical psychiatry. So what is precision medicine? I'm sure a lot of us must have heard about precision. In fact, it's a trending concept now in medicine. Another word that people are using to describe precision medicine is personalized medicine. What does it mean? It means that if everybody has malaria, right, and they go to the physician is going to use different drug for each person. That is the idea, right? So we are trying to move away from one size fits it all. Not that everybody has malaria, everybody will be given chloroquine or Fancida or anti-malaria, but each person will be treated according to the peculiarity of that person and the peculiarity of malaria that person is having. And that sounds utopic, isn't it? But that is where we are going. We have seen that being practiced in other subspecialties of medicine, but in psychiatry we have not been able to do that. So let's define what precision medicine is. It's a concept that deals with the treatment and prevention of diseases that considers each person's variability in those factors that can influence the disease manifestation, progression, and even response to treatment. And what are these variability factors? These variability factors include our genetic makeup, the environment in which we thrive, our chosen lifestyle factors, and so on and so forth. As I said, its concept is trending now, but actually it predates modern time. Precision medicine is a concept that predates modern time. It's been there for long, but it has not been able to attract as much attention as it is attracting now in the past. In fact, though it was officially launched in 2015 by the former American President Barack Obama, as far back as the end of the 18th century, as far back as early 18th century, some notable scientists have hinted on the advantage of precision medicine. And the first person that I want to quote here is Stuart Bernard, who noted that, look, when a physician is treating his patient, that patient as just a living thing, right? Or just a representation of the human race. You should see him as an individual with his own idiosyncrasies, not just in terms of behavior, but in terms of manifestation of the disease that the patient is presenting it, which makes him different from another person that has, again, the same disease. The second person I'm going to quote is Archibald Garrod. Archibald Garrod was actually a physician who specialized in molecular medicine. And he is actually considered to be the father of precision medicine. And he also said that when a physician is treating his patient, you should focus on the particular patient. You can see that highlighted in green. It is the focus on the particular patient. So what precision medicine is encouraging us is that, look, let's go away from that one medicine treats everybody and begin to focus on our patient. What is the peculiarity of this patient before you that makes him stand out, that makes him different from other patients that are having the diseases? And when I'm able to highlight the peculiarity of this patient, I will be able to tailor the most appropriate treatment for that patient. That treatment I've tailored again for that patient may not actually work for another patient that is manifesting the same disease. So what is precision psychiatry, which is actually the topic of today? It is precision medicine in psychiatry, subspecialty of medicine. So and again, the focus is to understand the underlying neurobiological mechanisms that are responsible for psychiatric disorders. It tailors interventions to the individual biology using neuroscience-informed knowledge. So we can see that what precision medicine is preaching is that we need to bridge the gap between neuroscience and clinical psychiatry, incorporating the knowledge, the excellent knowledge, the excellent research that we've done in neuroscience and begin to apply it in clinical psychiatry for the good of our patients. We connect each patient connects every patient to his own most appropriate treatment, and it highlights or it allows us to answer the question, our treatment, for whom is it going to work and how does it work, right? And you can see that precision medicine is actually from two words, precision and medicine. So the precision aspect of it is highlighting of measurement. If you go to the dictionary and look for synonyms for precision, one of the synonyms for precision is measurement. And it is here, that precision is also highlighting the concept of measuring, which means that if we are able to understand the biology of psychiatric diseases using our neuroscience knowledge, we can begin to develop biomarkers. Biomarkers are biological markers, right, that we can quantify and be able to know what is the degree of severity of our disease, and again tailor that to particular treatment that will match that severity. Now, I mentioned in my introduction that, I mentioned one of the things that inspired me to choose this topic, which is the fact that it appears our contemporary psychiatric care is not doing enough. It's not getting to the level that we expect it to get. And let us look at the statistics that can tell us how well or how good our psychiatric care is. And we can only measure that based on the clinical outcomes, isn't it? So let's see the clinical outcomes that we'll be able to achieve with our contemporary psychiatry. The WHO published that the leading cause of disability now, globally, right, among all diseases, is diseases of mental illness. The leading cause of disability. And it's also reported that 1 out of 7 people globally has a mental health condition. What that means is that before we count 8 people among us, one of us has a mental condition. If we extrapolate that to the world population, the current world population is about how many? Does anybody know? What's the current world population? An estimate. Can somebody help me out? 8 billion, you say? Yeah. So if you have about 8 billion people living in the world, what does that translate to? It means almost 1 billion people are living with mental health disorder. Scary, isn't it? It doesn't end that. The WHO also said that every 40 seconds, once the clock clicks 40, one suicide occurs in the world. Quite scary, isn't it? And apart from that, it has also been estimated that the mortality due to mental illness surpasses mortality contributed by every other disease, especially among the young people, 18 to 24 years. Very scary, right? And again, apart from all of this physical body, what about the emotional body? The emotional body of psychiatric disease was aptly captured by a guy called Polymorphism, and I quote, "The tragedy of life is not death, right? But what dies in one when that person is alive." And as you know, that this aptly describes the emotional body of mental condition, not only for the patient, as well as caregivers. People that are having mental condition will testify to this. So, with all these statistics, I think it is right to make that assumption or conclusion that yes, our contemporary psychiatric care has a lot to do, right? And if it has a lot to do, what are we doing presently in contemporary psychiatry that we are not doing well? Where do we need to improve? I mean, somebody said the only way to predict the future is to create it, isn't it? Right? So let us try and find out. And you can't solve the problem. You can't expect to be doing the same thing and expect a different result. So if we continue to practice contemporary psychiatry the way we are practicing it now, the best we can have is to sustain those figures, which are scary. So we need to do something new. So what do we need to do? But again, we still have to go back to the contemporary psychiatry to find out what are we not doing well. Where are the lapses? Where are the gaps? Today, the root cause, the biological root cause of psychiatric disorders is mostly unknown. We don't know it. Yes, there are theories. Professor Owolabi today talked about neurotransmitters. We have this neurotransmitter theory, the monoamine theory of depression, which assumes that people have depression because they have low level of monoamines in their body, in their brain. So what we do is that we look for drugs that will increase the monoamine, and we expect it to bring, succor to the patient. Yes, it's doing that, but it's not doing it very well. Another thing, which is also a very wrong approach that contemporary psychiatric uses, is the fact that we assume that psychiatric diseases are mere functional disorders. They don't have morphological basis. And to some extent, it's true. When you look at the brain of patients suffering from psychiatric disorder, you hardly find any major change in their brain. Their brain looks normal. Yes, they have some little changes here and there, some brain shrinkages, expansion of the ventricles. You can see all of those things. But those things, can we actually point them to specific psychiatric diseases? Are they specific? Of course, no. So, because of that, we assume that, mental health condition is a functional disease and therefore has no biological basis. And And it has been discovered that that is not entirely true. Yes, it may be true that we may not be able to identify those biological changes using existing clinical tools. Like you do your maybe MRI of the brain, it's normal. So there is no biological change. You do your scan, it's normal, there is no biological change. Even when they do postmortem on some psychiatric patients, you don't see any change in their brain. So that gave us the assumption that there is no, it's merely a functional disease. We cannot compare it with neurological disorders, where we can see that clear morphological changes in form of lesion, in form of neurodegeneration. That's not there in psychiatry. But we forget to admit that maybe those tools that we are using, right, to examine our brain, that are in the clinic now, maybe they are not sensitive enough to pick up those changes that are responsible for driving psychiatric diseases. Maybe those changes are so subtle, right, that we cannot pick them up with the existing tools that we are using to examine our brain. Maybe we need to discover new tools that are more sensitive, that will be able to discover the biological basis of our brain. And because of that, even let's go into the clinic. The guiding principle, the constitution of psychiatry today, is a document called Diagnostic Statistical Manual. It's a document that gives the guidelines for doctors to establish diagnosis of psychiatric diseases. That document, DSM, is periodically reviewed by the American Psychiatric Association. Another document that is also used as a guideline for doctors for diagnosis of psychiatric disease is the ICD, International Classification. Compare all of these figures with other specialties. I'm going to start with cardiovascular medicine. As recent as 1948, mortality from cardiovascular medicine was 50%. If two people have cardiovascular disease, one person must die. It took the death of Franklin Roosevelt, right, for us to wake up that, look, something must be going on. Let us study this disease deeper. We should be able to do better. And that inspired the popular Framingham study in 1948. And that Framingham study actually gave birth to most of the revolutionary changes that we have today in cardiovascular medicine, and of course, the mortality has nosedived. And as a result of that study, research was done into the biology of cardiovascular disease, into how we can stratify cardiovascular diseases using the biology, and again matching those biologies to treatment. That is precision medicine. The same thing in oncology. As about 3 decades ago, when somebody like me was in the medical school, every patient that had breast cancer must go on a drug called tamoxifen. Mortality was almost 100%. Breast cancer was a death sentence. Today, because of the rich knowledge that we have gotten from genomics, metabolomics, and all other medical field at the research level, today we have heroes of breast cancer, don't we? We have survivors of breast cancer. Because today, if people that come with breast cancers are stratified, they are classified based on the biology of breast cancer. Today, with biotype cancer, with genotype cancer, to know what kind of genotype it is, which is going to dictate the treatment that the patient is going to take. Are we together? So if these two subspecialties of medicine have been able to make this progress, why can't psychiatry? Right? And it's been agreed that, look, the time to do that revolution in psychiatry is now. We can't continue to wait and witness the kind of scary statistics that we have presently. So what is the missing link? What do we need to do? What are the gaps that we need to fill in contemporary psychiatry for us to be able to achieve those laudable outcomes that we have seen in oncology, in cardiovascular medicine, and other specialties. Yes, we identified that there is an complete gap between contemporary psychiatry and neuroscience, and that gap needs to be filled. As I said, other things heavily rely on modern technology to inform diagnosis. That is not the same in psychiatry. Organic substrate of diseases have been largely ignored by contemporary psychiatry. Treatment options remain focused on signs and symptoms, ignoring biology. And it means that we need to study the biology deeply for us to be able to develop biomarkers and reclassify our diseases, not based on the symptom classification of DSM or ICD-10, but a classification that is based on the biology of the disease. So we need to start asking questions. What are the brain functions that are affected, and what are the processes involved? And what is the bridge between the causes and the symptoms of psychiatric diseases? So there should be a paradigm shift. We should shift from symptoms to biology. And in shifting from symptoms to biology, let us start from the basics of what we know about the biology of the brain. We all know here that brain is responsible for behaviors. And if there's going to be a change in behavior, there must be a change in the brain. Isn't it? Fine. And neuroscience has advanced, with the study of the brain. And it has provided insights into what we call neural circuits. And I'm happy the two lecturers that spoke before me, or the two speakers that spoke before me, also spoke about neural circuits. What are neural circuits? The wirings in the brain, right? Our neurons, the synapses, those are the neural circuits. What we call the microcycles and the macrocycles. The microcycles are the individual neurons. The macrocycles are the billions of neurons that are coming together, synchronizing themselves together, to bring out, to form the biological processes that are responsible for our behavior. And again, neuroscience has been able to confirm that dysfunction within these neural circuits are responsible for the abnormal behaviors that we see in mental health conditions. And understanding these dysfunctions offers us the opportunity to begin to objectify mental health conditions as opposed to the subjective approach that the contemporary psychiatry was using. So it means since we identify the biology, we need to study it. How do we study these neural circuits? Again, my lecturers, my speakers have also talked about neural circuit mapping today, especially the second guest lecturer when he was talking about fixing the brain tissues. So at the preclinical level, in rats, in rodents, there are anatomical tools that we can use to map out these circuits. At the clinical level, we have also been able to invent tools that we can use to map out these neural circuits, study them. And tools that we use at the clinical level for the study of these neural circuits can be divided into two major groups. We have the imaging group, that is, they help us to image the brain, and we have the electrophysiological tool. The electrophysiological tools are the tools that measure the output of the electrons because of their electrical activities. So we have the EEG, which I'm also sure some of us are familiar with, that is electroencephalogram, right? That measures the electrical activities that is in the brain. The patient comes, you attach electrodes. You attach electrodes to his core, and those electrodes are able to pick the electrical activities of the brain. The second one is the MEG, magnetoencephalogram. Because of those electrical activities, magnetic fields are also built up. And we can have sensors that can also pick up those magnetic fields on the cranium
and again register it for us. But the one we are going to focus on today in our lecture is the MRI, right? Most of us are also familiar with the MRI. Some of us have had, the experience of going to the MRI chamber and getting the structure of our internal organs, examined, right? But the MRI, the conventional MRI, or the conventional MRI is just like picture, right? It's like taking picture. But we have advanced MRI, and MRI actually stands for magnetic resonance imaging. But we have advanced beyond just taking pictures with MRI. We have gone to the level of doing movie with MRI. And what does that mean? The patient is in the chamber, right? And the functional MRI is able to capture what is going on in the brain real time, right? It's able to capture the workings of the neurons real time. So, for example, as I'm speaking now, there is a particular area of my brain that is very active. If I'm doing this under the MRI is going to show me that particular of the brain that is undergoing high level of activity as a result of my activity. If I stop doing what I'm doing and I go to rest, right, the functional MRI will also show me that that area of the brain that was hyperactive when I was talking has gone to calm down. Another part of the brain has been activated as a result of my resting. So it's like you are watching the brain in real action depending on the task that you are performing. So with that tool today, we can actually map our brain, map those neural circuits that are involved in different activities or in different behaviors. So it means that we can pull patients from the population, psychiatric patients from the population, and by the time they are having their symptoms, we can use the functional MRI to map those circuits that are active in these patients when they are performing their task. And if we look at patients having similar symptoms, and we are able to map a particular section of the brain to the common symptoms that these patients are having, and all of the patients are demonstrating activity at a particular part of the brain, then it makes sense to say that particular part of the brain is responsible for that symptom. Right or wrong? Does it make sense? Are we together? Good. And this is what we've done in neuroscience. So when we are able to register activity across many patients in a particular type of the brain, when they are performing the same function, we can map that circuit to that particular function. So let's say, for example, we have depressed patients. About, let's say, 10 depressed patients. Out of those 10 depressed patients, about 3 of them have prominent cognitive dysfunction syndrome, which means they are not able to do proper thinking, they are not able to execute highly cognitive tasks. If we scan these patients, these 3 patients, and we observe that all of them have a particular type of the part of the brain that is being hyperactive during functional MRI scan, then we can say that particular part of the brain is where the problem is, isn't it? So we can cluster these 3 patients into that group. And we can again confidently say that because the other 7 patients are not having high activity in that particular area where those 3 patients are having activity, it means those 7 patients are different biologically. Though they've been labeled, all of them have been labeled as depressed patients, right? So we can now cluster those 3 patients and form a new taxonomy, a new classification. And that new classification is called biotyping, biology typing. We have typed those patients into that group based on their what? Circuit dysfunction. The remaining 7 can do the same thing for them. Scan their brain, look at the commonalities in terms of the site of activity on the brain, and also typing. The beauty of this is that those researchers that are working, on this technology have also been able to identify treatments that are best suited for every particular biotype. I don't know if you understand what I'm saying. They've also been able to look at all the available treatments and say, okay, those guys,
that have cognitive dysfunction, that have a particular
site of the brain that is responsible
for their symptoms, right? Among all the drugs that are available for treating mental disorder, we've been able to pick one out of them that best suits that biotype, that biotype best responds to. So if you have a patient that is coming to depression, instead of you subjecting him to the rigor of contemporary medicine, go and take it. If it doesn't work, come back, we will replace it. Meanwhile, time is going. Before he comes, before your next appointment, you may not be able to see that patient again because he must have home himself. With this, once you see a patient, you take him functional MRI, determine the site of dysfunction in the central nervous system in the brain. You know the appropriate drug that best suits that patient. You start that treatment immediately. You don't need to do any trial, right? So what does that mean? You are being precise not only in your diagnosis, but again what? But in your treatment, leading to faster recovery, higher efficacy, higher remission rate. So if TSA by ICD-10 were classifying by symptoms, right? Circuit biotyping or circuit mapping is classifying, by biology. So again, I've talked about all of this, but I want to emphasize this. All of these, initiatives about biology of psychiatric diseases. I told you it was Barack Obama that launched precision psychiatry in 2015. Precision medicine in 2015, but it's currently being applied to psychiatry. But the framework that actually encouraged the application of precision medicine in precision psychiatry is a framework called the research domain criteria. Also an initiative of the US government, sponsored by the National Institute of Mental Health, right? And they released a lot of funds to researchers to go and look for the biology of psychiatric disorders, right? And that work, that initiative actually has produced a lot of interesting research with a lot of interesting outcomes. And we are looking, into one of them deeply today as we go into the course of the lecture. But before we look into it, okay, I think it's time for us to look at one of those works. There was a work that was pioneered by a wonderful woman, Leanne Williams. Leanne Williams is a psychiatrist who has an ER doctor as a husband. Young couple, the husband fell into depression. He was too ashamed, too stigmatized to go help because he's a doctor, and he thinks that once that is disclosed in his medical history, it's going to affect what? His profession. When the suffering became too much, unfortunately, he took his life. Right? And that gave her wife, Leanne, that big inspiration to push for what again is the biology behind depressive disorder. And using AI and circuit biotyping and benefiting from the research domain criteria initiative, she initiated a study in people that have major depressive disorder. She pulled these patients together and started scanning their brain using their functional MRI. And she realized that 90% of the patients that she studied, 90% of them have dysfunction in 6 major areas of the brain. 90% of them have dysfunctions in 6 areas of the brain. And the areas of the brain that she discovered are these. In these 6 areas of the brain, and she then the first one is the default mode, the second one in no particular order, it's the salience mode, the negative effect mode, the positive effect mode, attention mode, and cognitive mode. Mind you, these circuits are also present in normal people. But in depressed patients, they begin either overfiring or not working optimally. So she discovered that in the patients she recruited, 90% of them have dysfunctions in this circuit. So before we go into the implication of their dysfunction, what do they do? Let's examine them one after the other. The first one, which is the default mode circle, is what you and I use for our chilling when we are alone and we are reflecting about our memories, present memories, projection for the future. Yeah, when we chill out, relaxing, and we are thinking. So that is what the default mode is for in normal people. Internal stimuli like pain, visceral pain, or external stimuli. And it guides the switching of attention according to the stimulus relevance. So stimuli that are relevant receive the appropriate attention. Stimulus that are irrelevant will not, receive your attention. And the dysfunction in this cycle can lead into difficulty in distinguishing salient cues. And that results in you avoiding things that you are not supposed to avoid. Things that are not threatening, that are not supposed to be a source of threat, you begin to avoid them. Right? And that is also common in the symptomology of depression. The next one is the attention circle. This is what helps us to focus our attention. I'm talking to you now, you are paying attention to me because this circle is hyperactive. For those people that cannot focus, this circle is what? Is underactive. So if you are not able to focus your attention to me in this lecture now, it means that you have a dysfunctional attention circuit. Yes. Right? Hello, that's what you like that. Don't be scared. The next one is the negative affect circle. And this is the circle that helps us to react to negative stimuli. Threats, fear, sadness, right? And when we react to this type of negative stimuli, that place gets lit up under the functional MRI. For people that have hyperconnectivity in these circuits, right, they are said to be in the alarm mode. What does that mean? Because of the, thank you! Do that again. Exactly. They are in the alarm mode. Subthreshold impulses would trigger the alarm. And it leads to this panic-like behavior. Right? It leads to this panic-like behavior. The positive affect circle is what the part of the brain that is responsible for processing our reward. Professor Owolabi also talked about that today. The ventral tegmental area, the nucleus accumbens. Anything that brings a reward, like Jesus. In depressed patients, there is a hypoconnectivity in this circuit. The circuit is not performing optimally. So things that are supposed to bring reward doesn't shock you. They are not interested, right? That is also what we call anhedonia or anhedonia, lack of pleasure. And the last but not least is what we call the executive circle, the cognitive circle, the cognitive composite. That's what helps you in thinking, in performing highly executive tasks. And in patients that have dysfunction in that circle, hypofunction in that circle, what happens to them? They have what we call cognitive fog. Their ability to think gets frozen. They are not able to perform easy, simple tasks. They have what we call cognitive fog. And we have patients that have severe cognitive impairment in depression. Is my lecture boring? But people are sleeping. And when people are sleeping in my lecture, it discourages me. Are we fed up? Am I boring? You want to take a break? All right. Let's go on. So, with the work of Williams, the work of Williams has actually gotten us to a level or a platform where we can begin to answer questions. One day we can begin to answer precision medicine or precision psychiatry related questions. For example, why does a particular treatment modality work for patient A, but does not work for patient B? I think we can begin to answer that question now, right? So again, we can begin to go away from the one-size-fits-all, right, to precision psychiatry, precision psychiatric strategy, using neurocycle biomarkers to define treatment. So this is the work done by Williams and co-workers in Stanford. They worked at the University of Stanford. The company that backrolled the project is called X-ray, and that is why it's called the Stanford X-ray Brain Imaging Technology. So again, as I said, they were able to define those biotypes or those circuits in their patients with depression. After determining those circuits, they were also able to develop a metric system for measuring the degree of dysfunction in the circuit. And they developed a 10-point system from 0 to 10. Right? And the middle of it, which is what, 5, is assumed to be the normal score. So when you go through the functional MRI is able to tell us your score in the activity of these circuits. So if you have 5 in all of them, then you are fine, right? You are emotionally balanced. You are not suffering from any symptom of depression. If, for example, the cognitive circuit scores, let's say 1.6, what does that mean? It means probably one is entering cognitive 4, isn't it? You are not having enough activity in that circuit. And that, again, will manifest symptomatically in the patient. The patient will present with the cognitive type of depression. So after biotyping, you can see, the individuals there with different colors. That corresponds to different colors, different biotypes. And as I said, they've also been able to match available treatments, most suitable treatment to each of the biotypes. Right? So let's now go back to our comparison. I compare cardiology and oncology to psychiatry at the beginning of my lecture. So let's now compare the two with this kind of technology available for psychiatry. Let's take a cardiovascular patient. The cardiovascular patient comes to the clinic and complaining of a vague symptom like chest pain. What does cardiology do? It goes through investigation. Right? One of the investigations that we can also do in cardiology is an MRI. With the investigation, what are we looking for? We are looking for the biology of the chest pain. Is this chest pain as a result of coronary artery disease? Is it cardiomyopathy? Right? So at that level, what are we doing? We are stratifying the patient according to the biology. If it's going to be a coronary artery disease, well, isn't it? We give him drugs that will be able to restore the blood flow in his coronary blood vessels, isn't it? If it's cardiomyopathy, the treatment is going to be different. So again, we are tailoring a patient that has a common symptom, or we are tailoring patients that have common symptoms into different biological types, biotypes, which will ultimately determine the kind of treatments that they are going to have. So you can have 10 patients coming into the clinic with the same symptom, chest pain as a diagnosis, but each of them will be taking different drugs based on their biology. So it's not more sound utopic, isn't it? Fine. So let's go to psychiatry. If you are able to extrapolate this to psychiatry and also use this biotyping method to stratify our patients to these different levels, to these different causes, to these different circuit dysfunction, we can also begin to tailor different treatment modalities to different patients based on the biotype to which they belong. Are we still together? So this is a typical example. A patient comes in, depressed patient. He goes into the MRI chamber and we perform functional MRI in him. And I forgot to tell you, how does the functional MRI, how does it work? It works by detecting a signal called the BOLD signal, B-O-L-D, blood oxygen level detection signal. The activity of our brain, again, Professor Owolabi alluded to it. Our brain survives on what? On energy, right? We call our brain a predator. That predates on energy, right? But it's actually a predator. It not only predates, it also gives command, to the organs to continue to work while sapping their energy. So it works on energy, it works on oxygen. So what the BOLD signal stands for, it is measuring the rate of consumption of oxygen by our brain cells. So the more the activity, the higher the score. The lower the activity, the lower the score. So let's go in here now. So the patient comes, the depressed patient is in the MRI chamber. We've done the functional MRI, and the slide below there is reflecting the scores of the different circles. As we can see, the default circle, tension circle, positive affect, salience and negative affect, all of them are around 5, isn't it? So they are not doing badly. Am I correct? So which one? Can you remember? Yeah. For those patients, when they have a high score, it has been discovered that the drug that best works for them are the SSRI groups of antidepressants, selective serotonin reuptake inhibitors. What are the take-home messages? 1, the same diagnosis in psychiatry does not mean that they have the same biology. 2, neural circuits dysfunctions are relevant biological substrates of psychiatric disorders, and biotyping presents major shifts towards biology-driven psychiatry. Neural circle polymorphism fine-tunes precision psychiatry, and the future of psychiatry is what? Precision psychiatry. Thank you very much for maintaining your attention service throughout the lecture. Let us use the remaining few minutes we have for questions. Yes, please.
Thank you very much, sir, for the wonderful lecture. I must confess, I really enjoyed the lectures now. I have a few questions and a comment. Okay, so I will start with my comments. I just want to ask her that please can you share this slide after this?